This is a 52-year-old lady. She was an overseas patient from North Africa. And she presented to us with severe pain in both her knees for a few years with a significant deformity in the right knee. The first thing she said when she walked into my OPD was, "I want to walk." She'd been wheelchair-bound for 2 years. And you know, when you look at certain people, you wonder, should I be attempting this? So she'd been refused treatment at multiple centers overseas because she came with the rider that I want to walk. She had a past history of hypertension, and when I saw her, she was wheelchair-bound with a varus deformity with 10 degrees fixed flexion in the left knee. She had a massive varus in the right knee with some amount of fixed flexion. She had thickening of the bone medially and posterior medially below her tibial tuberosity. There was no tenderness. She had no distal neurological deficit. And this was her X-ray. This is what she walked in with.
All right, so Peter, you want to tackle this one?
Sure. So you can see what looks like a non-union of the distal metaphysis of the tibia. You can kind of see it on the lateral better, just the bottom of it there. That looks like a non-union. There it is. Okay, perfect. So you have a non-union, chronic. She had a history of trauma? I missed that. She have a...
No, she had no history of trauma.
Okay. So you worry about metabolic bone workup, obviously this being a spontaneous fracture non-union. Going forward with this for reconstruction-wise, we saw some nice examples earlier today of trying to correct this through the knee with a long stent implant and shish kebabbing it, reaming it, and getting that to hopefully heal with bone graft as well. So those are some considerations.
So did you do any bone metabolic workup?
We did. That was her when she walked in. And I often ask for an X-ray scanogram when I see one of these. So we wanted to see what's going on anywhere else. Significantly, when she, because of the back pain, we got an MRI, and she had severe spinal stenosis as well. Her vitamin D was in her boots, and all her parameters were normal. But when we worked her up, she had a positive W2 mid-stress echo. Fortunately, the angiogram revealed mild disease. This is what we planned. She underwent a laminectomy and spine surgery, and about a week later, we did the left knee replacement. She became all right with that, and I thought she'd go away. But she came back to me. She persisted, and she came back and said, "I want to walk." So we went ahead, and we did a simultaneous, that was a deformity. So she also had a tibia that was rotating inwards distally. And unfortunately, I didn't have permission from her to show intraoperative photographs. But what I've done is as you said, we've done a simultaneous osteotomy. We did a midline scar, incorporated the distal part of the non-union, freshened the edges, and did a dome-type osteotomy, rotated it back, and fixed it with a stem. Unfortunately, I changed institutions, and the institution wouldn't give me the lateral, so that's all I've got. This was done a few years ago. She sends me lots of patients. She's walking, but she hasn't made contact with me again. So this is her, just after surgery. So this is what we managed to get after the second knee.
Okay, Rajesh, you have a comment?
You didn't have to open up the fracture area at all.
We did, sir.
Osteotomy area you had to open up.
Well, limited. We incorporated it into the incision with the knee replacement. So we freshened up the edges, and when we did a dome time, it aligned back very well.
Right. I'm surprised you didn't need anything on the fibula, because looking at it first, you would think that you may need something on the fibula to bring it back.
We thought about that, but possibly should have done that. It fell back into position so well. And I've been reading a few papers ever since, which sometimes they don't do a fibular osteotomy. But yes, I take your points.
And talk to me about your fixation. You had cement fixation in the proximal fragment, but press fit distally?
Yes, sir.
Correct? And that was to allow for compression?
Yes.
Okay. Does everyone agree with that plan?
Yeah. Maybe because it was proximal, you didn't need a fibular osteotomy. Pretty proximal.
And did you assess rotational stability of that construct?
We did, sir. We did.
Okay.
Any role for a sleeve here in the tibia, Amar?
Would I? I mean, you don't need to. One thing I will say, and I'd be interested to hear what the panel thinks, we kind of went crazy with the sleeves and the cones. And I think we may have overutilized them. I don't know if anyone has a comment on that. But yeah, I don't think this needs a cone.
I don't think you want one here, honestly, because I'm a little afraid that it would stop everything from compressing. So I don't think you want it here. But in terms of sleeves and cones being overused in revisions, I don't really think so, because in the era where we didn't do metaphyseal fixation, there were quite a few pretty good-looking constructs that loosened by 10 years. So I would say sleeves and cones, not a bad thing to do.
Okay. Anything else? Anything more in your presentation?
No, sir, we're done.
Okay, thank you very much.
Thank you.